Today I'll be demonstrating a case of cervical encirclage. The procedure that I've chosen is McDonald's procedure simply for the ease of it, and you'll be more benefited by it because it's a more practical suture. So this was a case which came to me. She was the third gravida. There were previous two histories of recurrent mid-trimester abortions, specifically categorizing as painless cervical dilatation and followed by expulsion of the fetus. So obviously, when she came to me in this pregnancy at around 14 weeks, 5 days, I was actually observing her on serial ultrasounds, and it showed cervical shortening. So the decision was taken of doing a cervical encirclage, and she was posted for it. Now, pre-op investigations, baseline investigations you have to do, which are there for the pregnancy, obviously, like ABORH, CBC, RBS, and most importantly, you want to see whether there is already an existing infection there or not, because in that case, cervical encirclage might get complicated later on. She might go in again in labor, and she'll blame you for the procedure for the same, and lots and lots of complications can arise. So very important is to check for any local infection, amongst which urine culture is also very, very important, and a CRP, a baseline CRP. You would definitely want to see the placental localization, the status of the fetus. That means if it's already a congenitally malformed or a compromised fetus, why would you want to give a cervical encirclage? So there are certain basic pre-op investigations which you need to do for medico-legal purposes and otherwise also. And obviously you have to document the cervical shortening your way also. So, we have taken this cervical encirclage procedure. McDonald's have chosen for you to demonstrate. Now, we are starting with the procedure. As you can see here, we've chosen an umbilical tape. And the needle is very, very robust needle, strong needle. We call it the cutting needle, or trocar to be more specific. It's a big, big needle in which you can thread this umbilical tape. So, you should know that. Okay, pre-op patient was, the bladder was emptied. Obviously, I checked in all the pre-op investigations. She was kept on an injectable antibiotic, which is it's non-specific antibiotic. There is no specified antibiotic which you've got to give before the procedure. But yes, any cephalosporin group antibiotic which does very well with patients in pregnancy can be given to her. Now, what we're doing is, you've already seen one stitch was taken at the 12 o'clock position. We are now going at the 9 o'clock position, followed by a 6 o'clock position, and then again at 3 o'clock position. And then this is a purse string suture which we are going to take, and we will tie the knot at 12 o'clock position. And I'll tell you more about the knot tying when we reach there. But before that, let me just brief you a little over here about the different sutures which you can use. So you can use monofilament sutures for the simple reason that there is infectivity rate is low. But remember one thing, that it's very, you're using two speculums. Can you see that? The two sim speculums are being used. Two sponge holding forceps are being used, basically for holding the anterior and the posterior lip of the cervix separately. The needle, well, you can use cutting needle also, you can use round bodied also, but remember that you're taking the stitches through the cervix tissue. It is not entering the cervical canal. So when I say that you will see the placental localization, remember that if it's a low-lying placenta, the risk should be explained. But you already know that you're not entering the cervical canal, so the manipulation might lead to hemorrhage, bleeding, anything can happen which has to be explained to the patient. But it's lower edge touching the os is not a very big contraindication for a cervical encirclage position. And remember that you're doing it 14 weeks or 14 to 16 weeks when the placenta can very well be low-lying. So you should always do that placental localization thing, but you're not entering the cervical canal. That thing also you should know. So now we're tying it at 12 o'clock position. What we check over here when we're tying it is that we put one finger inside the cervical canal. Can you see that? It should not enter. Your suture should be that tight that it should not, the finger should not enter. It's a purse string suture. We moved from 12 o'clock to 9 o'clock, then 6 o'clock, then 3 o'clock, and we're tying it at 12 o'clock again. But now have a look at this. You know what happens is that when the cervix, it grows, it advances with the pregnancy, this knot that you just tied, that gets embedded somehow in the cervical tissue. So it becomes very difficult to take out that knot. So see what you're doing. Can you see what we're doing? We're taking another series of knots at a distance from the previous knot, and now we'll cut it simply for the simple reason that it should be easy for us to remove the suture at a later date. Now, if she goes in frank labor at any point in time now in pregnancy, so that's an indication to remove the suture. Otherwise, you will remove the suture once you're sure about the baby getting mature enough, lung maturation tests, or at obviously after 37 weeks, you can remove the suture whenever she is. Now, remember one thing, that if she is already in labor right now, the cervical shortening is because of labor. It's a contraindication to give McDonald suture or any cervical encirclage suture. So, well, that was all about cervical encirclage. I took the most easy one because that's expected of you from examination point of view. Shirodkar is a more complex procedure because in that case you'll have to, go a little up, and you'll have to, kind of dissect the bladder away. You should know though about it. Then I was talking about suture, so let me finish it over here. You can take silk number 1. You can take Proline number 1. You can also take 5mm Merceline tape, which has got very good prognosis when it comes to cervical encirclage. And you should always remember to tie the knot which is tight enough so that your finger does not go inside. It should not cut through the cervix. You have to be very, very gentle in this procedure. And with this, I finish with the McDonald suture, cervical encirclage. I hope you've understood, and if there are any other doubts, please feel free to WhatsApp me. I'll love to help you.